Hello everyone. Today let's study about chronic obstructive pulmonary disease, otherwise called COPD. Chronic obstructive pulmonary disease, or otherwise called chronic obstructive airway disease, is a group of condition in which there is a chronic, partial or complete obstruction to the airflow at any level from trachea to the smallest airways, resulting in functional disability of the lungs. So COPD can affect any level of the lungs, that is in the trachea or to the bronchioles or bronchus. So it has 4 or 5 types that comes under COPD. Out of that, there are two important conditions. Among that, chronic bronchitis and emphysema is the most important condition. Others are bronchiectasis, bronchiolitis, etc. So chronic bronchitis and emphysema is actually an overlapping condition where it can occur in same patient, that is it can frequently occur together. So there is a condition like predominantly chronic bronchitis or predominantly emphysema patient. That is mainly distinguishing with the help of clinical features. So chronic bronchitis and the emphysema have similar etiology, and out of all the etiologies or the reasons, the most important is smoking and the pollution. So smoking, as we all know, the cigarette smoke contains so many chemicals, both the inorganic chemicals or the tar, etc. So these actually cause damage to the lungs. The important damages that is imparted by the smoking is, the first one is it impairs ciliary movement. As we all know that cilia is a protective factor in the lungs, which helps in trapping or expelling or eliminating the particles, microorganisms or the dust particle away from the lungs or out of the lungs. It inhibits the smoking also inhibits the function of alveolar macrophages. We all know that alveolar macrophages helps in fighting against the microorganisms. So while inhibiting the function of macrophages, that makes the patient susceptible to develop infections. Okay, and the third is it leads to hypertrophy and hyperplasia of mucus secreting glands. Mucus secreting glands is goblet cells, and submucosal gland mainly produces the mucus in the respiratory tract. So these glands produces mucus, and the mucus is very much helpful in trapping the microorganisms or the dust particle, and through coughing it is eliminated out. So in this smoking or the cigarette smoke mainly causes the overproduction of the glands, and it thus over secrete the mucus. Okay, so there is a overproduction of the mucus, and thus there is a there is too much of coughing, and there is too much of obstruction in the lungs. And also it causes the considerable obstruction of the smaller airways, and it stimulates the vagus nerve and causes the bronchoconstriction. The second important factor is pollution. We all know that the industries or the automobiles eliminate or exhaust so many chemicals to the environment. Out of that, the very important one is sulfur dioxide, nitrogen dioxide, and toxic fumes, etc. So that increases the risk of developing chronic bronchitis. And the other minor factors are occupation, as we already discussed in the asthma. Occupation, like the workers who are working in cotton mills or in flour mills or in plastic factories or in asbestos industries, are exposed to various organic or inorganic dust. And the next is infection. Infection in the sense like bacteria or viral or mycoplasmal infections. They actually do not initiate or start up the chronic bronchitis, but rather it usually occurs secondary to bronchitis. That is, whenever a patient is having bronchitis, then they are, or the bronchitis patient have increased risk of developing infection. Familial and genetic factors are poorly defined relationship, like they are not that much very important in developing this emphysema or chronic bronchitis. But even though in emphysema there is a minor effect of these familiar or genetic factors in it. So let's have a look on chronic bronchitis. Chronic bronchitis is a common condition. It is defined clinically as persistent cough with expectoration on most days for at least 3 months of the year, for 2 or more consecutive years. This is the condition for satisfying the diagnosis of chronic bronchitis. So the cough should be persistent with expectoration, and it should be for at least 3 months in a year for 2 consecutive years. Okay, so this is the condition. Yeah, the key features are mucus hypersecretion and bronchospasm. So when you think the chronic bronchitis, you should remember there is a mucus hypersecretion. There is the overproduction of mucus and the cough. Okay, so cough and mucus. We all know that mucus is good for us, right? But too much of good things are bad. Yeah, so too much of mucus is harm to us. It affects mainly the smaller airways like bronchioles, and it have the patients who have chronic bronchitis have increased rate index. As I told you that the cigarette smoke causes overproduction of the glands, that is hypertrophy and hyperplasia of the mucus producing cells. These rate index will be increased. So what is rate index? Rate index is the ratio between the thickness of the mucus gland to that of the total bronchial wall. Okay, so how much is the difference? So normally there is 40% or 0.4 is the ratio between the thickness of submucosal glands to that of the total bronchial wall thickness. Okay, so in chronic bronchitis patient there is increased rate index. That means there is a submucosal gland, or the thickness of the gland is increased. Okay, there is an increased thickness of glands in the chronic bronchitis patient. So that is more than 50% will be there. So whenever there is a chronic irritation of airway, then there is a hypersecretion of the mucus, and also the ciliary damage will be there. The excess mucus will be blocking the airway, that causes the obstruction. Okay. General pathophysiology is that whenever there is an irritant on the airway, which is starting, it is not chronic, it is just starting. So as a response of the host, the host will produce, or the human, as we produce mucus and ciliary activity to expel the irritant. That's quite normal. So we will expel the irritant by means of cough with expectoration, that is with the sputum which contain the microorganisms or whatever may be. But if there is a chronic irritation, okay, if there is a chronic irritation or repeated infection in the respiratory tract, then there is a hypertrophy of the hyperplasia of the goblet cells or the mucus producing cells. So that causes the mucus hypersecretion. Yeah, and along with that the vagus nerve influence will be there, and that causes the bronchospasm or the sudden narrowing of the bronchial smooth muscles, bronchial airway. Also the ciliary damage. So these conditions together bring about to form or to make chronic bronchitis. What are the clinical features? When we think of chronic bronchitis, we should think that it is blue. Okay, bronchitis blue. Yeah, so just think that it is blue blotters. The patients who are having the bronchitis will be called as blue blotters. Why blue blotters means? Let's split the term blue and blotters. Blue means it is due to the cyanosis. Okay, that is the airway will be, or the alveoli will be filled with the mucus in the chronic bronchitis. Okay, so in such patients the mucus will be filling the airway, so the oxygen will not be perfused into the body. So the body will not get enough oxygen, right? So the body will not get enough oxygen, and also the carbon dioxide cannot go out because the alveoli is always already filled with the mucus, right? So the gas exchange will not happen there. So as a result, the carbon dioxide accumulation in the body causes cyanosis. So that causes the bluish appearance of nail beds, white of the eye, lips, etc. tongue, etc. Okay, so that is the blue. Why blotters means? There is a fluid buildup in the body that causes the patient to look like bulky, and also the patient have to excessively put force for inhalation. Yeah, for breathing the patient have to put extra force. When you are sucking, or when you are sucking a milkshake or a kiwi shake through a straw, so if it is obstructed in the straw, if some fruit pieces are obstructing in the straw, you have to take extra breath, right, to inhale. Yeah, so such appearance causes the patient to call like a blotter. Okay, so the edema and also the extra force to breathe in, that makes the patient call like a blue blotter. And persistent cough with copious expectoration of the long duration, that is the key feature in the chronic bronchitis. The cough will be there with excessive expectoration will be there, that is the copious expectoration. Okay, so it initially begins in a heavy smoker with morning catarrh or throat clearing. That is, there is an obstruction in the airway that causes the patient to wake up in the morning like producing a sound like yeah, that is the morning catarrh. Okay, which worsens in the winter. And also in chronic bronchitis there will be recurrent respiratory infections. Yeah, and also dyspnea on exertion. And remember, in chronic bronchitis always the cough will be the starting point. Okay, and cough is followed by dyspnea. But in emphysema, it is just opposite. Dyspnea will be followed by the cough. Okay, yeah. So recurrent respiratory infection, dyspnea on exertion, blue blotters, increased risk of developing right heart failure or cor pulmonale, increased risk of fibrosis of the lungs, and diagnosis at around the age of 50. So that's about the chronic bronchitis. We'll look on to the emphysema. So the WHO definition of emphysema is that it's the combination of permanent dilatation of air spaces distal to the terminal bronchioles and the destruction of the walls of the dilated air spaces. Okay, so there is a dilation of air spaces and the destruction of the walls of the dilated air spaces. We'll come to that, what is happening, I'll tell you. So thus is defined morphologically while chronic bronchitis is defined clinically. So that is the difference. Okay, emphysema is morphologically defined, that is in structure wise it is defined, while chronic bronchitis is defined as clinically. Yeah, that is based on the signs and symptoms. So since the two conditions coexist frequently in a patient and show considerable overlap in their clinical features, it is usually used to label the patient as predominant emphysema and predominant bronchitis, as I told you earlier. Yeah, before going to the type of the emphysema, let me just remember you that in respiratory tract the trachea will be dividing into two main bronchus, and each main bronchus will be divided into bronchioles, and each bronchioles at the end it is called the terminal bronchioles. Okay, and this terminal bronchioles will again divide into respiratory bronchiole along with the alveolar sacs. Okay, so acinus is called 3 to 4 respiratory bronchioles along with the alveolar sacs. So that is called the acinus. Okay, so an acinus is respiratory bronchiole, 3 to 4 respiratory bronchioles along with the alveolar sacs. Okay, so 5 such acinus. Okay, 5 such acinus, that is called the plural, we will call acini. 5 such acini is called a lobule of the lungs. Okay, lobule of the lungs. So depending upon the portion of the acinus involved, emphysema is classified into centriacinar, where the inflammation is occurring in the center of an acini. Panacinar means fully, that is the emphysema will affect the full acinus, throughout the acinus. Paraseptal, irregular and mixed. Okay, so going to the pathophysiology, let me just tell you, for an alveoli, if it need to expand and recoil, okay, if the oxygen is coming in and it will expand, carbon dioxide will come in and it will while exhaling the alveoli will be recoiling, right? The alveoli will be snapping back like a rubber band. Okay, so for a alveoli to recoil back into its original shape, they need a protein called elastin. Okay, so this protein is very much important for maintaining the elasticity of an alveoli. Got it? So in the emphysema, what is happening is there is a deficiency of elastin. So if there is a deficiency of elastin, that causes the loss of ability or inability of alveoli to recoil back to the original shape. So there is a destruction of the alveoli wall, so that the alveoli cannot recoil back. So what will happen? The alveoli will left open, dilated or inflated. Okay, so watch this video when in COPD. Yeah. Let me pause it. Yeah. What will happen means the alveoli cannot recoil back. So there is a air already in the alveoli will be trapped. Okay. Air will be already in the alveoli, right? The oxygen is coming in. Yeah. So this oxygen which is entering will be trapping in the alveoli. That causes the expansion or leaving it open. Okay. It is not recoiling back. So oxygenation will be there into the tissues. Okay, the hypoxia will not be there in the patient because oxygen is coming into the blood, but the carbon dioxide cannot go out. Yeah, for exhaling it is very difficult, but in bronchitis inhaling is difficult, right? Yeah, so that is the different. So the trapped air is the important feature, remember. So while the air is trapping in the lungs, the patient cannot deflate like a normal lungs or cannot exhale like a normal person. Okay, so this is it. Yeah. Okay. Yes, do not deflate like a normal lungs. So as I told you, elastin. Yeah, elastin is a protein that helps the alveoli to recoil after it's being inflated. So we have an enzyme in the body called elastase, which is derived from the neutrophils, and it has the capability to digest the lung parenchyma itself. So this elastase will be inhibited by an enzyme called anti-elastase. It is called alpha-1 antitrypsin. Okay, this alpha-1 antitrypsin, it is otherwise called alpha-1 protease inhibitor or elastase, anti-elastase. Okay, so this anti-elastase which is synthesized from the liver, and it inhibits the elastase from being damage the elastin. Okay, so it inhibits the protease or elastase and thus protect the elastin from degradation. We will call that enemy's enemy is a friend, right? So alpha-1 antitrypsin is gonna indirectly or directly help the elastin to do its job. Got it? So this elastin is protected by alpha-1 antitrypsin in a healthy adult. Okay, so this the locus of the antitrypsin gene is found in chromosome 15. That's why I told you there is a small genetic influence in the emphysema patient. Okay, so alpha-1 antitrypsin helps the elastin to do its job, or it prevents the elastase to degrade the elastin. Okay, so in COPD what will happen means there is an imbalance between elastase and alpha-1 antitrypsin. You can guess already, right? As I told you, the normal function, normal in healthy adult, what will happen. Then in emphysema, you can guess what will happen in emphysema. So in emphysema, there is an imbalance between elastase and alpha-1 antitrypsin. That is, there is an increased elastase activity due to increased nuclear infiltration, and also there is a decreased alpha-1 antitrypsin activity due to its deficiency. Okay, now you can guess. What will happen if there is an increased elastase activity? The elastin will be, that protein elastin will be destroyed. Okay, so this, whenever the protein elastin will be destroyed, what will happen then? The recoiling capacity of the alveoli will be stopped, right? So the alpha-1 antitrypsin activity will be decreased due to its deficiency and increased elastase activity. So together it will cause the destruction of the alveolar wall and loss of recoil capacity. So you can easily understand from the picture. So there is a damage of the alveolar wall. So now you can guess the definition. Yeah, we have already read out the definition, and in the definition it is clearly stated that together, like it's a combination of damage of the alveoli along with the loss of recoiling capacity. Okay, so the air will be trapped inside the alveoli and oxygen entry will be there into the tissues, so that the patient will remain well oxygenated, and carbon dioxide exit will not be there. So the patient will have to struggle for exhalation. So the main culprit behind the emphysema is smoking. In smoke, there are so many components which inhibit the alpha-1 antitrypsin enzyme and increase the protease or elastase enzyme. Okay, so there is an inhibition of alpha-1 antitrypsin enzyme by oxidant in the smoke, and there is an increased inflammatory cell recruitment. So this, whenever there is an inflammatory matrix, that is ECM degradation will be there. So from the neutrophils, the elastase enzyme will be released. The elastase is otherwise called protease, okay, and the alpha-1 antitrypsin is otherwise called antiprotease, okay. So increased protease activity and decreased antiprotease activity will lead to elastic damage and emphysema. So smokers have up to 10 times more phagocytes and neutrophils in their lungs than non-smokers. So thus they have very high elastase activity. Yeah, that's it. So the clinical features of emphysema is, as in the figure, it is pink puffer. The patients is called pink puffers. Yeah, why means they remain well oxygenated. Yeah, but they have tachypnea also. And one more thing that I have missed to write in this clinical features, the lips will be pursed. That is, lips will be open in the patients suffering from emphysema. Why? Because due to exhalation, or they are just exhausted due to the respiration, or by using the accessory muscles for respiration, they are very much exhausted. Okay, so there is long history of slowly increasing severe exertional dyspnea. As I told you, in emphysema, first one is dyspnea. Initially dyspnea will be there and it is followed by cough. Cough means it is not that much as related to or compared to bronchitis. And the patient is quite distressed with obvious use of accessory muscles of respiration, because the lungs have to pull out into the accessory muscles. We know the accessory muscles of respiratory systems, right? Costal muscles, intracostal muscles, like that. So they have to use the accessory muscles for respiration to exhale out. So due to that use, the chest will be barrel shaped and hyper resonant. Okay, because they cannot exhale properly. And the cough occurs, and also due to the air trapping. That is why they are called the barrel shaped chest. Cough occurs late after dyspnea starts, and it is associated with scanty mucoid sputum. Scanty mucoid means the mucus will be less as compared to the bronchitis. Patients are called pink puffers. As I told you, weight loss is very common, and no frequent respiratory infection, and while comparing to the bronchitis. And diagnosis will be at around the age of 60, because as I told you, there is a 5 types of emphysema, right? So in pan-acinar or centri-acinar, that is very common. In pan-acinar or centri-acinar, the alveolar wall damage and the clinical features will be very late. Yeah, even though the patient will be smoking from the age of 20 or 25, and he will develop the slowly he will develop the dyspnea, but the clinical features, the exact features of the emphysema will develop only at the age of 60. Yeah, that is the main problem in the emphysema. So the diagnosis will be late. So that's about the COPD. Hope you understood. I'm not going to the treatment level, just the pathophysiology. So if you have any doubt, please feel free to pinch me. So thank you so much.